Excelente. Pues bueno, muchísimas gracias, Químico Carlos. Vamos ahora a continuar con el programa científico. Y pues nuevamente tenemos la participación, en este caso nuevamente el doctor Giovanni Fogazzi. Vamos a abrir aquí para que vayan colocando aquellos que requieren la traducción o que requerimos la traducción. Aprovechamos estos minutitos para prepararnos.
This is ready. Okay.
Yes.
Okay. I do apologize for being here again, but I promise this is the last time. So be tranquil. Allora, the topic of this presentation is the identification of atypical malignant cells in the urinary sediment. This presentation has two limits. One is that the images I will show are images all taken with phase contrast microscopy. There are no images taken with stains. And the second limitation is that I will describe only atypical malignant cells deriving from the uroepithelium. Okay. What are the atypical malignant cells for friends EMUC? They are cells which differ morphologically from the normal uroepithelial cells. Their presence in the urine sediment is due to inflammatory disorders or malignancies affecting the urinary excretory system. What is the urinary excretory system? Is the system which, starting in the kidneys and going down, collects the urine which is produced in the kidney parenchyma. So the whole urinary excretory system includes renal calyces and pelvis, then the ureters, 1 and 2, the bladder and the urethra, okay? All this urinary excretory system is lined by uroepithelium, which is a multi-layered epithelium, which, as I said, goes from renal calyces to bladder in female and up to the proximal urethra in men. And what is very interesting is that it is a multi-layered epithelium. This is the lumen of the ureter. Here is the sample coming from ureter, and here we have the basal membrane, and we have the deep layers, and then we go through them up to the superficial layers. And as you can see very easily here, you have small cells with an increased high nuclear cytoplasmic ratio. And then as we go up, the size of the cell increases and the nuclear cytoplasm ratio decreases. Here I show you other images, beautiful images of ureter. Again, deep layers and superficial layers. Small cells with a large nucleus, larger cells with a smaller nucleus compared to the cytoplasm. Other images. Again, you see here these cells, which are very different from these ones. They have in common the fact that they have one nucleus, but the size and the nuclear cytoplasmic ratio is totally different. Here, the last example. Occasionally, the superficial cells may also have two nuclei, but usually they have mostly one only nucleus. And these are the deep transitional cells as can be found in the urine You see the scale there, which gives us the idea of the size. Large nucleus, small cytoplasm. What is this? What is this? What is this? Sì, ma quale eritrocito? Isomorfico, ok. Bravo. And here again, we have another deep transitional uroepithelial cell. Another example. So we have in the previous images, we have oval, sometimes, let's say, oval cells. Here in the next one, we have club-like cells, which are very common as deep uroepithelial cells. And here we have a clump of normal uroepithelial cells from the deep layers, club-like, you see here, and here no more club-like, okay? At times, it may be difficult to distinguish this type of deep uroepithelial cells from renal tubular epithelial cells. In that case, it is very important to look around and to see what is the global context of the urinary sediment. Because if you found cells, and we are not sure, renal tubular or deep transitional cell uroepithelial cells, if there are red blood cells, in the first case, renal cells, they will be glomerular, dysmorphic. If they are associated with uroepithelial cells, they are isomorphic. If it is renal tubular cells, we will have casts, which are not usually present in urological diseases. For some reason, it's not working. Perché non va? He's tired. No, okay. Here we have examples of the superficial uroepithelial cells. Unfortunately, here we don't have a scale bar, but they are much larger cells compared to the previous one. Small nucleus compared to the cytoplasmic surface. Often there is a clear halo, a clear perinuclear halo, okay? And the size, and not only the size, but also the shape is very different compared to that of the deep uroepithelial cells. Here we have other example. Here it is an ovoid, the superficial uroepithelial cells. Here are other examples. And here we have two clamps at small magnification and high magnification, okay? So two different main types of uroepithelial cells, deep and superficials. And it is important to know that when we have superficial cells, they are commonly found in urine. For instance, if you have a patient with cystitis, they are frequent, the superficial cells. But when you find deep transitional cells, one has, especially in high number, more than one per hour per field, it is very probable that the patient has a urological disorder, okay? This is what we have also published in our, at pages, as a table, at page 74 of our book, not this one, but the book, the third edition of urinary sediment. So the deep transitional cells, even when they have normal morphology, you see if in high number, they are indicators, markers of urological disorders or of the presence of a bladder catheter or a ureteric stent. And now we start speaking about atypical malignant cells, AMUC for friends. Their main morphological features, as they are described in this landmark book. They have an increased cell size and unusual shape, such as tadpole, fiber snake, etc. An enlarged nucleus, more than 25 micrometers, with increased nucleocytoplasmic ratio. And or unusual nuclear shape, fan, heart, helmet, crescent, etc. And or enlarged nuclei, more than 5 micrometers, and or increased number of nuclei, more than 3, and or coarse irregular chromatin granules and variety of chromatin sizes, and or multinucleation, and or cell aggregates. So to show all these possible images, I will, to know that the greater the morphological changes of a MOOC, the higher the probability is of the presence of a malignancy rather than an inflammatory disorder. A MOOC due to malignancy are always associated with variable amounts of isomorphic erythrocytes. So if we find cells like this with isomorphic red blood cells, cancer is very probable. And now I will, these are the different types. I will describe 3 patients with bladder cancer and urine sediment. And these are the different types of bladder cancers which can be found, okay? And most of them, some of them have a very deep, a basis throughout the wall of the vessel of the bladder, while others are not. We will see. The AMOC found in the urine sediment of 3 patients with bladder cancer, 3 clinical cases. Patient 1, a man with macroscopic hematuria. In June 2007, a 55-year-old Eritrean man is admitted to our hospital in Milano Policlinico, nephrology, for gross hematuria, abdominal pain and fever associated with serum creatinine of 4.5 milligram per deciliter. Ultrasounds of the abdomen show a solid mass in the bladder and one in the right kidney and the left hydronephrosis. Very unhappy urinary tract system. Dipstick, pH 5, specific gravity 120, albumin 4+, hemoglobin 4+. Urinary sediment more than 100 isomorphic red blood cell per hyper field, and a high number more than 1 per hyper field AMUC, atypical malignant cells. We have a macroscopic hematuria with 4+ albumin in a patient who has a urological disorder. Why do we have 4+ albumin? Simple, because when we have a macroscopic hematuria due to urological disease, there is a loss of blood, entire blood, full blood, which contain albumin. So it is not albumin coming from the glomeruli, it is albumin which comes from the blood itself. So, working hypothesis, solid mass in the bladder and the right kidney, macroscopic non-glomerular hematuria, and many AMUC. Probable cancer of the bladder and kidney. The AMUC found in the urine sediment of our patient. Are you ready? Okay, we go on. Look, here we have many isomorphic red blood cells, either non-ghost and ghost, and this very unusual cell. 74.5 major diameters and a large nucleus with 1 large nucleus. Here we have normal transitional cells, maybe some white blood cells. Other cells, you see here, tadpole cell, a typical unusual shape and size, 44 to 50 micrometers, okay? And this is at a low magnification. Then we have another type of cell like this, an elongated cell with 2 large nuclei. And here, normal transitional cell, red blood cells isomorphic. Another one at a high magnification, look, 61 micrometer long, large nucleus and 1 large nucleus. Another similar cell. Okay? Here we have a snake, long 76 micrometers, with this enlarged nucleus and again 1 well-evident nucleus. Another cell of this type, with a very coarse chromatin pattern, I would say. And here we have a clump of atypical cells, okay? And the presence of clumps is another sign of malignancy, or inflammation. And we took the renal biopsy, cystoscopy. During cystoscopy, the bladder biopsy, and these are the cells which we have found in the bladder, in the tumor, in the cancer of this man, in the bladder of this man. And in fact, look, what we have found in the bladder wall is very similar to what we have found in the urine. So the urine sediment is not only a liquid renal biopsy, is a liquid biopsy of the whole urinary system. Non è che funzioni proprio benissimo. Is sleeping. A volte va, a volte non va. Quello che sto schiacciando da mezz'ora. Ok. Now let me go back. Okay? Okay. Patient number 2. A man with pericarditis, but not only. In February 2008, a 62-year-old man from Burkina Faso. This is a patient whom I am followed up in one of our missions to West Africa, Sub-Saharan West African Benin Republic. A 62-year-old man from Burkina Faso is admitted to the medical ward of the Saint-Jean-de-Dieu Hospital, Tangueta, Northern Benin Republic, for pericardial effusion associated with dyspnea and lower leg edema. Renal function and urinalysis are normal. We started the diuretic treatment for all with oral furosemide to reduce the cardiovascular overload. And in order to monitor the diuresis over the 24 hours, we insert a bladder catheter. No. Okay, and after the bladder catheter insertion, we find that the pH is okay. Specific gravity 115, hemoglobin 3+. Hemoglobin was not present before, albumin absent. Urinary sediment, the day before it was normal, now we have 40 to 60 isomorphic red blood cells per eye power field, and plus more than one AMUC per eye power field. Which AMUC we have? These are, we don't have the possibility to measure with the microscope we have in Africa. So they are cells, large cells. Look, you can compare the diameter with that of red blood cells with unusual shape and large nucleoli and multinucleated, 2 nuclei here, 2 nuclei here. And again, we have a large cell with unusual shape and 1, 2, 3, 4, 5 nuclei. Here, 1, 2, 3 nuclei. Are these cylindrical cells? I ask you think that this might be a cylindrical cell? You don't know. Okay, I go on. Then this might be a so-called cylindrical cell. Again, a large, very large cell with the elongated shape with 1, 2, at least 3 nuclei. Here again, a large cell with 2 nuclei with 2 large nuclei in each nucleus. And then we have 2 other types of AMUC, okay? This one with 2, 3 nuclei, and the other one with very unusual shape. Now I'm joking, and believe me, I'm joking. This is a very malignant cell, very malignant. Do you know why? Does this cell remind anything to you? I'm joking, eh? So I do apologize, but you know why I consider this very malignant? Can I say that? To me, it is Trump-like cell. Is that true? I didn't. There is no Photoshop. It is. At that time, Trump was not yet president, so not Photoshop. Is it true, no? Okay. Minor diagnosis. The day after the presence of a large bladder solid mass is confirmed by cystoscopy. However, in Africa, at that time, biopsy was not available. Due to the overall clinical condition, no treatment is started because it was a very systemic bad situation. Quite interestingly, subsequent urine sediment examination are all normal. Therefore, it is hypothesized that it was the procedure of bladder catheter insertion per se, which scraped the atypical cells from the cancer mass, which was demonstrated by the cystoscopy. Now we have the third and last patient. A 70-year-old man followed up by me in our clinic, nephrological clinic, followed up since 2002 in our renal clinic for stable CKD, serum creatinine 1.6, proteinuria 0.6 to 1.5 gram per 24 hours, with few iodine and iodine granular cast in the urine sediment, with type 2 diabetes mellitus, high blood pressure, and obesity as comorbidities, and the drugs which are usually used for these conditions. One day, on October 30th, 2008, during a routine checkup in the renal clinic, the urine sediment examining external laboratory reports the finding of severe microscopic hematuria, which was absent before, 2,000 red blood cells per milliliter, which had not been noticed before. At this point, I asked the patient to supply a new urine sediment the day after, in order to see if it is true or not that the microscopic hematuria, which was absent before, has actually appeared. And in fact, he came the day after with the urine sediment, which we examined in our lab. pH, specific gravity, 1+ albumin, hemoglobin 3+. Esterase, leukocyte esterase, nitrites negative. Red blood cells, the presence of red blood cells is confirmed, isomorphic 100%. A few white blood cells, no renal tubular cells, uroepithelial cells, 4+ of AMOC, and cast 1 to 3 iodine and granular. So albumin and cast reflect the basic situation of this patient, while hemoglobin and uroepithelial cells tells us the new situation which has arrived and superposed to the basic situation. And these are the atypical cells. You see two large cells with the enlarged nucleus and very evident nucleoli, a very big cylindrical cell, I would say, with two at least nuclei and large, very large nucleoli, another atypical cell, another atypical cell with large nucleus and two very large nucleoli, a cluster, a clump of cells, and again clump of cells, of atypical cells. And then look, we have these cells with very enlarged nucleus, very thin cytoplasm, and look, an inclusion body like as bird cells, okay? And here we have these cells in clumps. And again, look, cell with a large nucleus and large nuclei, and look at this. This is a cell which a very large nuclear inclusion with the morphology appearance of Iber cell. At this point, I have a question for you. Again, other examples of these cells with very large nucleus. Okay. Further workup, the presence of a solid mass in the bladder is confirmed by the abdomen CT scan. After a bladder biopsy, which confirms the presence of a cancer, unfortunately, we were unable to recover the histology of the cancer. A radical resection of the solid mass is performed. Teaching point. The appearance of microscopic hematuria in a patient with a usually bland urine sediment must always alert the clinician. At that time, it was the clinician who also examined the urine sediment, so it was a very added value. As in the case described, this finding, the presence of red blood cells, which was not present before, this finding may be the first sign of a cancer, of bladder cancer, which is more frequent in men over the age of 50, and the patient was 70 more. Okay. At this point, I have a question for you. Do the cells shown in the last 3 slides, and we will go back to them, bring to your minds another type of cells? So I go back to the last 3. 1, 2, 3. And I go 1. These cells, in your opinion, may be misidentified or may be are very similar to other types of cells. Which one? I hope that an answer will come from those who participated to the practical course we ran 2 days ago with Fiorella Anghileri. The COI cells, that is true. The COI cells, which type of the COI cells? Which type? No, this is type 1. Type 1, this is type 2, okay? Okay. Okay, we can go on. Yes, they are really very similar to the cells, to the COI cells, type 1 and type 2 we have seen 2 days ago. Yes, which one? How to distinguish the 2 types of cells? Okay, cells with the COI cells associated with BKV reactivation. They, with variable morphology, yes. The same happens with urothelial cancer, even though the morphological spectrum is much wider. Cell aggregates, they are not common in BKV reactivation. They are frequent, common, typical finding in patients with urothelial cancer. Red blood cells are not usually present in patients with the COI cells, where they are present in patients with urothelial cancer. White blood cells are absent, while in BK reactivation, they are present in cancer. Macrophages, they are present, as you remember, and they are absent in this condition. Final comment. The examination of the urine sediment, especially with phase contrast microscopy, allows the identification of uroepithelial cells with atypical morphological features. Phase contrast does not replace more accurate cytodiagnostic techniques, Papa Nicolau stain, which represent the gold standard and are based on more sophisticated procedures. However, phase contrast represents a tool to raise the suspicion of inflammatory or neoplastic disorders of the urinary excretory system. We have published these 3 cases in 2015 in Clinica Chimica Acta, which is the journal of the International Society of Laboratory Medicine. Thank you very much. No, I have other images to show you. I was thanking myself. Other images of atypical malignant uroepithelial cells from our image archive. You see, again, snake-like, tadpole snake-like cells don't forget isomorphic red blood cells. Another type of this, another example of this very long cell. And now, atypical cells, you see here, unusual shape and size. Again, elongated cell with two nuclei and well evident nuclei. Unusual shape, very unusual, large cell with the chromatin aggregated around the nuclear border. Multinucleated cell. Again, large cell, very large cells, unusual shape and polynucleated, multinucleated. Again, binucleated cells, large cells. And here an aggregate of very unusual cells, unusual for morphology, and very large nuclei in their nucleus. Thank you for your attention. I finished at last. So I want to repeat the limitations of this presentation: only phase contrast images, no stains used, and only bladder cancer. We don't have examples of cells which can derive from kidney cancers.
Perfecto, muchas gracias. Nuevamente un fuerte aplauso al doctor Giovanni Fogazzi por su excelente participación. Vamos a iniciar ahí nuevamente con las preguntas. Veo por aquí ya una manita levantada, entonces vamos a iniciar.
Hola. Soy mala con el inglés, pero voy a intentarlo. How should I report the amuk cells in the exam? How should I report the amuk cells?
We usually write red isomorphic, hematuria, etc., and a high, moderate, low number of atypical uroepithelial cells. We don't write cancer possible because we cannot. So we suggest, we recommend the cytopathologic investigation of the urine. This is not to we cannot be sure, but okay, there are atypical malignant cells. No, there are atypical urothelial cells, and for this reason, we recommend a cytopathologic investigation of the urine.
Thank you.
That's very wise. No? Okay. Cylindrical cells? Have you seen cylindrical cells there?
No. You remember my yes. No, doctor. Again, very interesting, the figures. Mi dispiace perché io non parlo bene italiano. So
Nemmeno io, quindi.
So I continue trying in English. I can say you that with this technique, phase contrast microscopy, I think you can suspect the presence of cells, but as you say, it's necessary the confirmation with other techniques.
By the golden standard method, which is urine fixed in alcohol and Papa Nicolau.
Papa Nicolau, because many times there are overlapping of imaging, and as this technique mark the chromatin very intensive, sometimes it's it's difficult differentiating between something reactive or directly neoplastic. So I agree that it's necessary to make another confirmation, Papa Nicolau, for example.
No, I do agree. But what is important, the important message is that, again, with a very simple test, phase contrast, quick, inexpensive, okay, based on a very basic technology, microscopy and centrifugation, you can arise an important diagnostic hypothesis. Then, okay, and the urine sediment in Italy costs to the national public program system, €2.30. So with a very inexpensive test, if it is well done, you can give very important messages.
This is the
Important
first step.
information.
The first step on the diagnosis.
Yes, eh?
The first step in the diagnosis is the single
Yes.
observation in
Yes,
the
and
medical
then go
lab.
on. Okay? I think it's an important message.
Thank you.
And of course, in case you don't have face contrast, you may use, so with bright field, you cannot see all this detail. You can use Sternheimer-Malbin, Sternheimer-Malbin stain, okay, supervisor stains. Okay, other questions?
¿Alguna otra pregunta? ¿No?
Okay, good.
Pues bueno, vamos a proceder a entregar el certificado de esta charla del doctor Giovanni Fogazzi nuevamente.